Okay, thank you very much, Dirk. What I'm going to do is I'm going to do the trauma lecture, then speed into the do the spleen lecture, and then speed into the trauma lecture by using the spleen as an example of where you use contrast-enhanced ultrasound in trauma. So the spleen is the forgotten organ. Many people, including me, never even discovered the spleen until I was a fourth-year medical student when I was doing my pathology finals. But it's there, and nobody looks after the spleen. In your hospital, nobody will look after the spleen. So if you do find something in the spleen, you always struggle to find someone to come and look, physician-wise, who's going to deal with the splenic lesion. Now, what I'm going to show you is based on the guidelines. So in the non-hepatic guidelines, there is a section on the spleen. And there are 4 recommendations in this section. And if you can read it, it says it improves the detection of focal splenic abnormalities. It can characterize suspected accessory spleens. It can be used to diagnose splenic infarction, and it can identify benign focal lesions by showing persistent enhancement in the late phase. And these are fundamental points that you should keep in mind when we go through the lecture, because there's very little that you need to know about those focal spleens to make your diagnosis and present the case to your physicians or surgeons. So if you've got a patient with a focal splenic lesion, lesions showing low-level arterial enhancement and progressive late-phase contrast washout usually require further imaging or biopsy, particularly in high-risk groups. Focal splenic lesions with benign enhancing characteristics will be usually suitable for interval imaging. So those are basic principles for you. So what about the spleen? Well, you've got a spleen that it's of various shapes. It has notches, clefts, lobules, and accessory spleens. It can be big, it can be small, and you may sometimes be so small that you can't find it on your ultrasound examination. It may be in different areas. There is the wandering spleen. It need not necessarily just be up there, tucked up under the diaphragm. You can have more than one spleen. You can have several spleens in that area. And lesions in the spleen can be solitary or multiple, and you get diffuse disease as well, diffuse enlargement of the spleen. And of course, there's trauma, fractures and hematoma in the spleen. I always save this case for this meeting because this is a man from Munich. And this is a patient of Dr. Klevert's who presents with a testicular mass. And this is a splenogonadal fusion. You can actually fuse your spleen to the gonads, and you more often see it in men because they can feel it. But you can also fuse a spleen to your ovary, and it can be continuous or discontinuous with the spleen. So you get accessory spleens all the way down the embryological development to the testes or ovary in continuous, or discontinuous, you get a lump on the testes. And everybody who finds this takes the testes out. So there are about 150 cases worldwide reported. But it's an impossible diagnosis to make preoperatively. You can do a technetium scan, and this will show you accessory tissue in the spleen, but in the testes. But how often do you do a technetium scan when you find a testicular mass? Never. So this is Dr. Klevert's case. This is our case. This is pain in the left iliac fossa in a 6-year-old child. There's a mass in the left iliac fossa, and when you look at it closely, it's infarcted. This is an infarcted wandering spleen. So it can be, don't think your spleen is always in one place. So we've moved away from wandering spleen now, and let's look at something else. Solitary lesions. Well, solitary lesions can be cysts. They can be true cysts, hydatid cysts, or they can be post-traumatic. You can get a solitary hemangioma, a lymphangioma, a hamartoma, infarction, or abscess. Hamartoma, lymphangioma, probably quite rare. You can get multiple focal lesions. You can get metastases, lymphoma, infection, TB, or sarcoidosis in the spleen. The normal spleen behaves exactly like you would expect and see on a CT scan when you're doing perfusion. When you look at the CT scan, you get the zebra pattern on the CT. Now watch this video of that spleen, and you can see there's that zebra pattern coming through. And it takes some time, 30, 40, 50, 60 seconds to become normal. And it's exactly the same as on the CT scan, but you're seeing it dynamically. So that is a normal spleen perfusion with contrast-enhanced ultrasound. Splenunculus is an accessory spleen, and it's quoted to be found in up to 30% of patients. It may be single or multiple, and you can have up to 6, and they can be quite large. Normally at the hilum, but you can find it anywhere in the line of where the embryological development is. And you can mistake this for lymphadenopathy at the tail end of the pancreas. And contrast-enhanced ultrasound is useful in this context. Here we have a very large lesion on CT for renal colic, so there's no enhancement there. Just watch that large lesion enhancing with your contrast-enhanced ultrasound. And you'll see, and look carefully at the zebra pattern again, appearing in that splenunculus, and it looks like it would in the early phases of your CT or contrast, and there's a little tiny cyst in it as well. And it'll remain hyper-enhancing. So this is a splenunculus, which has exactly the same pattern of enhancement as the normal spleen. Infarction, if you have a patient with sudden onset of pain in the left upper quadrant, has endocarditis, and you may actually have an embolus there. And the classical embolus will be this wedge-shaped feature in the distal aspect of the spleen, which you may not see on your on your B-mode ultrasound. These may be quite large, in these areas of infarction may be quite large, but also not only in endocarditis, you may see it in myeloproliferative diseases, sickle cell disease, and collagen vascular diseases. So if you've got someone with left upper quadrant pain with this clinical history, and there is a suspicion that there might be infarction, adding contrast would be quite easy for your examination to confirm that. And dynamically, there's no issue about seeing that as an ischemic area in the spleen. An abscess, well, an abscess is not that uncommon in this spleen, and you will see it in your practice. And depending on the age of the abscess and the liquefaction, you may get these sort of appearances where a drainage procedure would not be suitable for an abscess. But this sort of appearance where there's liquefaction in the spleen, this would be amenable to an abscess if drainage if clinically indicated. Splenic granulomatous disease can also affect the spleen, and this is where it's a little bit more difficult. Here are granulomas throughout the spleen and liver in a patient with tuberculosis, and on contrast-enhanced ultrasound, there's hyperperfusion of these areas, and there's a little bit of washout later on. It's a difficult diagnosis to make on your contrast-enhanced ultrasound, but in this sort of situation where you've got multiple lesions in the liver itself, the diagnosis may be achieved by a liver biopsy for granulomatous disease. Metastases are uncommon, as intrasplenic metastases are quite rare, and usually this is from a melanoma from the breast or is bronchogenic. You're more likely to see serosal metastases arising from the ovary or endometrial cancer rather than intrasplenic lesions. But these look very much like metastases elsewhere. Remember, there's not a dual blood supply to the spleen as there is to the liver, and you're looking at brief enhancement and washout in the late arterial phase with these lesions. And they usually wash out. And again, think back to that first slide I showed you, to saying that if something washes out, it's likely to be malignant. And these are other views of metastases within the spleen. And this correlates with your CT examination, but clearly you see these very much better on your contrast-enhanced ultrasound, and you can observe it dynamically. So what about the evidence for splenic lesions? Well, there's not a lot of literature out there. These couple of papers I've picked up from the literature show a couple of things. This one, with only 30-odd patients in the retrospective study, showed that contrast improved the visualization of splenic metastases in about 40% of cases. So it's not telling you it's going to do it really well. And in the other paper, similar findings. They could differentiate benign from malignant lesions, but again, a small number of patients. And a further study later on found that this was, using SonoView in this case, it was useful to look at focal liver lesions because you can distinguish benign from malignant lesions. What about lymphoma? Well, it's not infrequent that the primary presentation of a lymphoma is a lesion within the spleen itself. And a lymphoma has this characteristic appearance on contrast-enhanced ultrasound, and this is the particular image you should be looking at for this, where it has this almost feathery arterial pattern with some slow washout in appearances. And you've heard from the lymph nodes that there is preservation of the vascular pattern through the lymph node, and it's a similar sort of thing in the spleen or the liver. There's some preservation of the normal blood vessels, and they don't look so malignant with the contrast-enhanced ultrasound. The only study I've been able to pick up, and this was in radiology some years ago, where they looked at splenic lymphoma, and they said that the pickup and diagnosis of splenic lymphoma was better, if not, and comparable or better than PET-CT. The commonest benign lesion in the spleen is the hemangioma, but it's not a typical appearance as you would see in the liver. It's normally echogenic, but not always so, and it's not normally found in adults between 30 and 50 years, and there's equal male and female distribution, asymptomatic, so you just find it on your examination. And here are comparable images of the CT and the contrast-enhanced ultrasound to show you those appearances quite clearly with infilling of that lesion in the portovenous phase, and the later phase on the contrast-enhanced ultrasound. So this is a very classical hemangioma, which you won't see that often in your practice. Lymphangioma is rare. I don't want you to go home to think that tomorrow you're going to find a lymphangioma on a spleen examination. It's slow-growing, it's a vascular lesions, maybe single or multiple, but there are pockets of cystic change within these lesions. It's present in children as a benign congenital malformation, and it can cause symptoms if it increases in size. And this is an early image from when contrast-enhanced ultrasound was grayscale, and it depicts it a little bit clearly, but you can't make the diagnosis other than by exclusion on the contrast-enhanced ultrasound, and there's the equivalent on your CT examination. Hamartoma, rare, only 120 reported cases worldwide, and these are images provided by Chris Harvey from London to show this hamartoma with vascularization on your color Doppler flow, and the appearances on the MR and the CT. Again, it's a difficult diagnosis to make, and contrast-enhanced ultrasound is actually variable depending on what the hamartoma is made of, and pockets of reflectivity, etc. True cysts are a little bit easier to make a diagnosis. You probably don't need a contrast-enhanced ultrasound to show the epithelialized true cysts that you can see in the spleen, and the pseudocysts from trauma that you may see some years later after even forgotten trauma. Hydatid cysts, of course, you relate this to the presence in an endemic area, and in the UK the endemic area for hydatid cysts is in Wales, so be careful when you're there. Other vascular tumours are even rarer than what I've demonstrated to you. The littoral cell angioma, pleosis, hemangiopericytoma, hemangioendothelioma, and angiosarcoma. I've only ever seen one of these, and that's a angiosarcoma. I've not seen any of the other lesions, so don't go away again thinking that this is the diagnosis that you're going to make. So let's have a look at this particular paper in the literature that's looking at perfusion of angiosarcomas in the spleen, looking at contrast-enhanced ultrasound, the wash-in and wash-out characteristics of an angiosarcoma of the spleen, and this is a very comprehensive paper. However, if you look more clearly at this, this is reported in Veterinary Radiology and Ultrasound, volume 52, in 26 dogs and 2 cats. So this is a very important paper because it cited one of my papers. That's the only reason I found it. And in fact, angiosarcoma is common in dogs. And this is why the veterinary community actually use a lot of contrast-enhanced ultrasound. One of my colleagues, consultant colleagues, brought a CD of his cat from Italy who'd had a contrast-enhanced ultrasound of the liver for me to interpret. I didn't quite get the answer, but that is commonly used in the veterinary practice. And the veterinary practice looked to the human literature for inspiration and also to see what's happening and relate it to the animals. So angiosarcoma is not an uncommon diagnosis in the dog and the cat. So for an incidental splenic mass that you see on your ultrasound examination, in the absence of findings to suggest malignancy or lymphoma, the most common echogenic solid or cystic mass is a splenic hemangioma, particularly if calcification is present. If increased color Doppler flow is present, consider a hematoma, but much rarer. Now I'm going to show you this case before we go on and talk about trauma. And this is courtesy of my colleague Tim Yusof. This is a man in his early 40s who presents with left upper quadrant pain, and this is a mass in his spleen. So this is clearly not going to be a benign abnormality, and this is very likely an angiosarcoma, very rare in these patients, in adults, in clinical practice. So what are you going to do with this? Well, in the United Kingdom, we refer these patients to the super-regional cancer units, and in this case, it's the Royal Marsden Hospital. But the Royal Marsden Hospital will not accept this patient to be transferred unless you have a histological diagnosis, because they don't want to be dealing with benign disease. So the instructions from the Marsden Hospital were that could you biopsy the spleen, take a minimum of 12 biopsies, because we usually can't get the diagnosis because these are cystic lesions. So my colleague, Dr. Yusof, said this was nonsense. He was never put 12 biopsy needles into a patient. So in fact, he used contrast-enhanced ultrasound to direct him to areas of solid tissue and sent 3 biopsies to the Marsden Hospital. All 3 were positive. So this is a practical tool for doing something and looking to get that histology, because this is important for the morbidity of the patient. 12 biopsies into the spleen. In the United Kingdom, you were worried about putting a 18-gauge needle into a normal spleen, so you can imagine putting a large needle. So very useful, practical tool in that. And there's the needle into the area. That's the most important area to have got vascularized tissue from. So in summary, I've already said this, there are 4 areas in the spleen that you're going to use contrast-enhanced ultrasound. Detection of to improve detection of focal splenic abnormalities, characterize suspected accessory spleens, diagnose splenic infarction, and identify benign lesions by showing persistent enhancement in the late phase. And those are the only 4 recommendations. And I've told you about triaging the patients with focal liver lesions. Now, in the next 5 or 6 minutes, I'm going to talk to you about blunt abdominal trauma using the spleen as an example. Now, blunt abdominal trauma means blunt abdominal trauma. There is no visible injury on the surface, okay? You've not got a knife sticking out of the abdomen, or you've not got an abdomen that's split open. This is blunt abdominal trauma. And the people who most mostly get blunt abdominal trauma are the children. They fall from the climbing frames, they fall out of bed, they get kicked by a horse. This is blunt abdominal trauma. Now, the practice has been in the past that you would use a fast scan in the emergency department. A fast scan is looking for free fluid. So you're placing your scanning in certain designated areas to look for free fluid, to actually say there is a rupture of something causing this free fluid. And fast scanning is a reasonable examination in an adult patient. But it will miss significant trauma. It will miss significant liver trauma, splenic trauma, whatever else. But it's the mainstay of in the emergency room. But this is evolving and changing over time because we do, as a level 1 trauma center, we have a CT scanner in the emergency department. But this is not for that benign blunt abdominal trauma. This is for the real major trauma where head-to-toe CT is done. But very often, with blunt abdominal trauma, with a stable patient, you are going to get a CT anyway. That's fine. But could you improve your ultrasound examination of blunt abdominal trauma in the A&E setting? Yes, you can by adding contrast-enhanced ultrasound, but it's very specific. And this is a study we did a number of years ago, mainly out of Italy, but it's a well-cited publication of how you can manage blunt abdominal trauma. Remember, with your contrast-enhanced ultrasound, you can only look at solid organs. So you're looking at the kidneys, the liver, and the spleen. You can look at the pancreas if you can see it and see if there's trauma to it, but that's the least area that's going to have damage in blunt abdominal trauma, unless specifically it's a handlebar injury from the child coming off the bicycle. It doesn't look at bowel, it doesn't tell you there's ruptured bowel, etc. So this specific study was to see if you could improve on your baseline ultrasound examination of the solid organs, not fast scanning, but extending it to solid organs, making it easy for you so you could just image the solid organs. So the study was set up that you had 2 doses. You gave 1 dose to look at the right kidney, a second dose to look at the left kidney, and then at leisure, you looked at the liver and spleen because you had enough contrast going around there, and then they had a CT scan. I just draw your attention to a couple of things here, and then I'll tell you about the spleen. On baseline ultrasound, they could only, and using the contrast-enhanced CT is the gold standard, you only could make a definitive diagnosis in 32 patients, but adding contrast, that increased to 120. So almost up to contrast-enhanced CT. So it made a big difference to your confidence in the diagnosis. And what it didn't see was not major issues for the patient, not something that was going to cause some problems. And it worked really well in the spleen. Why did it work? And why is it important in the spleen? This is the most common organ to be injured, particularly in children. So now let's take it out of the, and who's going to get blunt abdominal trauma? It's not your 88-year-old grandmother, unless they're riding a motorbike. And there was one patient of 92 who came off a scooter in Italy with blunt abdominal trauma. It's going to be your young adults. So this may change your practice a little bit, and it may change your practice in follow-up as well. So it's accurate in picking up the trauma. So if you have a patient with abdominal trauma, I think you're almost, and if you have some concerns about it, you're almost obliged to do the baseline CT. The baseline CT identifies for you the other outside of the liver, spleen, and kidney, any damage. But that's a different issue. That's if you've got someone who's symptomatic, low blood pressure, with blunt abdominal trauma, you're going to do a CT. There are 2 groups of thought in the pediatric patient. There's a group of people in Rome, pediatric doctors, who've actually used it as a triage tool in children. So if the contrast-enhanced ultrasound is normal, they get sent home. There is another group with pediatric trauma, and that's our group, who say, well, if they're being brought in by a helicopter and landing there, get the baseline CT. But the baseline CT will identify for you where the issue is. And thereafter, you follow it up with a targeted contrast-enhanced ultrasound. For instance, if the liver laceration, you're going to look at that liver laceration over time, so you stop that young adult or pediatric patient having repeated CT examinations and reduce that radiation. There is no point in irradiating the entire abdomen to look at one laceration and is that going to form a pseudoaneurysm. That is almost criminal to be doing that when you have a tool that will allow you not to do it. So these are just an examples of splenic lacerations, and you can see that on the CT scan it's really quite clearly seen. But remember that CT scan is contrast enhanced. You will not see it on an unenhanced CT. On the unenhanced B-mode ultrasound, you see a little bit of change there. But look how day and night that laceration becomes with your contrast-enhanced ultrasound. And I can tell you, when we first did this in the mid-2000s, this was sort of like we couldn't believe how good it was at looking at trauma in the spleen or anywhere else. So what you can do here is, and our practice is day 5 and day 7 to look at these patients before discharge, because that's the time it takes, and the complication is a pseudoaneurysm that you're looking for. You use the contrast to pick up any pseudoaneurysms before they send the patients home, because most of these patients with blunt abdominal trauma recover. So this is a young patient. I think this patient is only about 4 or 5 years old. But look at the CT examination and the issues with the spleen there. And this was before the days when we didn't do as much contrast-enhanced ultrasound. Now, this is a pediatric patient. You don't see things so well because there's no body fat. And you do your best to increase those pixels as much as you can, but you still won't be able to discern exactly what's going on. And you can only play around with that image so much because it's been presented to you, and that's it. This is what you have to look at. On the B-mode ultrasound, there are bits and pieces of lacerations and things. And in the color Doppler, you're not quite so sure what's going on in this area here. So let's just put on the contrast-enhanced ultrasound. And you see how diagnostically that becomes just a no-brainer, in that you can see that there's a small pseudoaneurysm there. It doesn't matter. You're probably not going to treat that pseudoaneurysm, but you're going to watch that patient. We don't tend to embolize the pseudoaneurysms in the spleen, but we tend to embolize the pseudoaneurysms in the liver because the bile stops that pseudoaneurysm clotting up and thrombosing. So it's more likely that this will resolve on its own, but not always. And then you follow this up. You know, instead of doing daily CTs in a 4-year-old, you're doing contrast-enhanced ultrasound. A 24-year-old girl, you're not going to do CTs that often. You're going to follow it up with contrast and make sure it's okay. And this is how we follow it up. So this is a patient who's actually had embolization of a pseudoaneurysm within the spleen, and that's the area of bleeding in the spleen here that we've picked up with an area of infarction, and you can see the vessels going to it. So that's been embolized, and you can follow up after it's been embolized, and you can see all the coils on your contrast-enhanced ultrasound. So that's where you use it in trauma, in contrast, and I've used the spleen to demonstrate this to you. And again, it's the same take-home messages for the spleen. Thank you very much.
So, Paul, every time I see a splenic lesion for the last 15 years, they ask me if it's a SANT tumor.
It's a what tumor?
SANT, S-A-N-T, an angioimatoid tumor of the spleen.
Yeah.
You didn't hit on that?
Yes, but it's not common, yeah.
No, of course it's not. I know, yeah. I said it for a joke. Hey, Paul, I found the recommendations from EFSAM were interesting in this regard. So my practice obviously is quite different, and I'm not in a trauma center.
Yeah.
But like, I don't actually I do follow perhaps the thing about the benign lesions, but in actual fact, the thing that helps me the most in my practice, which is a very high risk and high oncology practice, but when I see a mass in the spleen and it enhances and then it shows rapid marked washout, is I send it to either have a PET scan or to have biopsy, and those are almost all cancers. And now I know why you don't have that as one of your points, because there's not evidence, it's not
evidence,
published, and I've never published a single case.
Yeah, exactly. There's no evidence. If people can put it together and put it in evidence, it becomes a guideline. You can't tell people this is your guidance if you can't back it up.
No,
You're absolutely
no,
right.
I'm just making, I
making
thought
a
it was
comment,
great.
yeah,
I'm just making the
exactly,
comment that there's no question that washout lesions in the spleen, when they wash out black, those are going to be lymphoma and other things like that.
Exactly.
Yeah.
It's a general principle. Yeah,
Yeah.
if it becomes black, worry.
That's great.
Yeah.
But it was a great talk.
Thank you. Conrad.
I also enjoyed the talk very much, and I've got a question. We've got a growing number of, especially young women, who have multiple hypoechogenic lesions, and if you add contrast media, they are hardly perfused in all phases. And we biopsied some of them, and it was sarcoidosis all over. Yeah. Of course, we're a rheumatology unit as well in our hospital, but the thing is, what's your experience? I think it's well, in my impression, it's more and more.
I think, granulomatous disease of the spleen and sarcoid is something that's underdiagnosed. It's only because we image more and more that we see it. And the same applies to the testes. You see multiple low reflective areas in the testes, and you don't know what this is, but the serum ACE is elevated. Angiotensin. So this is also something that we don't know about, but will take time. But you're quite right. It's sarcoid and TB in my practice is another thing. Yeah. Doris.
I have one question. Back to the roots. What's the anatomical ground for the tiger pattern?
Zebra. I think it's
Spotted zebra. Those look more like a tiger.
a tiger. Okay, but let's not argue at this point. I think it's a differential perfusion of the pockets of blood that occupy the spleen. It's a mesh, isn't it? It's a mesh with pockets of blood in it, and I think it's a manifestation of that. Yeah. Is that right?
I talked about it earlier. It is a question of open and closed circulation, because some of the trabecular arteries end up in the red pulp without having a connection with the sinusoids, and others have a direct connection. So one is the open, the other the closed circulation, but it is probably much more complicated. And I read a paper in which it was said by a pathologist, probably the spleen is the most difficult organ regarding its architecture, its functional architecture. And that is definitely true. But what is interesting also is that there are some pathologies, like in liver cirrhosis, like in osteomyelofibrosis, you miss this zebra sign because the spleen is enlarged and you don't see it.
Yeah.
But you don't see it because you have another interest. In most cases, you are more interested in the liver or in another organ, and then you switch to the spleen, and then you say, oh, the spleen is enlarged, but everything is fine. But you do not look at it at the first time, at the organ, and that is why you often don't see that.
Any other question? Doris, I give you the microphone.
One more morphological. When you have children, they have an infection or they have some oncological disease, and you take a high-frequency probe, you see these little hypoechogenic spots in the spleen. Is it red and white pulp? What is it? We call it always like activated spleen. But what is it? Can you tell me?
I don't know. Do you know Hans-Peter? He knows.
We've seen that also, and not only in children, but also in young adults.
Yeah.
I have no idea. It only can be seen if you It can only be seen when you use really a high-frequency probe, like 15 megahertz or above.
I mean, this also,
Since-
when we
since-
looked at COVID in the lung.
Since
with contrast.
Since COVID, I'm in pathology department now, and the thing is, it's a cruel command. But the thing is, the only way to find out is if somebody dies, you have to do post-mortal biopsies and have to correlate the specimen. Then we know that's the only way. Otherwise, it all stays very hypothetic. Yeah, but maybe in some people who die not, and then we can have at least the answer to this question.
Okay, that was a very practical comment. But we have, pardon me? Oh, we have a comment from outside.
Yeah.
In case of sarcoidosis, are the lesions iso or hyper perfused in the arterial face? This is the question.
Well, they're low
for you.
reflective on your B mode, and that's how you pick them up. And they're usually very hypo-perfused and then wash out. Is that your experience, everyone else? Yeah, yeah.
Okay,
So-
thank you.
And the same with granuloma from TB. They behave in a similar way.
Okay. I have a question I was waiting for this session. Actually, it's another case that I have, and I don't know what it was actually. It was a young woman that had a cystic lesion that I found in ultrasound around 5 centimeters that was confirmed by an IRM as a cystic lesion. She returned after 3 months with the same lesion, and I asked her to come again after 6 months. After 6 months, there was nothing. The spleen looked completely normal, and I took her once again to a CT this time. It was completely normal, and they said that probably it was a cystic lesion that just broke.
Reabsorbed, yeah.
But she never had abdominal pain, nothing.
And how big was it?
Around 5 centimeters.
Extraordinary, yeah.
Diameter. It was really large.
Okay.
And I was wondering if you have any experience with this, because I don't know how to...
To manage it, no.
Yes.
No, I haven't seen a cyst that large regressing in the spleen. You understand?
Thanks, Hans-Peter. I think that we see lesions in the spleen and the liver that resolve spontaneously. And we see masses in the abdomen that I think look like nodal masses, and before they're explained, they can regress as well. And so I don't know what they are, because anything that goes away, I always reassure the patient this is better. Anything that goes away, we're not worried anymore. So come back and we'll keep watching you. But I think that spontaneous regression happens of quite a lot of things. And I even had the most unbelievable, gigantic FNH in a liver of a unusual personality lady when I was in Toronto, and she wanted me to keep looking at it when I moved to Calgary. So she started to send me pictures, and then when she sent them to me one time, it was gone. So then I sent her back to my friends in Toronto. I said, I need you to do a personal scan and the CEUS, the works. And so where did it go? I don't know. But I mean, it was like big. So things go away.
Conrad.
We've had a funny porter in our hospital, and he had a giant renal cyst, and I was really, he was a nice guy, so we controlled it and everything. And one time he came back and there was no cyst anymore, and we asked him, everything all right? Yeah, and he said, yeah, there was this pain, but it was only a slight pain and things like that. So sometimes they rupture, in fact, and there's some case reports from Italy, and it was really good to know. Maybe, I don't know, was there an experience of a trauma or something like that? Nothing, yeah. All right. Too easy, okay. Okay.
So the take-home message here from Conrad
What a poor patient.
The take-home message from Conrad is you've got to be a nice guy before he sees you.
But this, we need to have a drink soon, because this is degenerating into a conversation.
Call a halt.
But we actually have another patient that I remember that had definite abnormalities on scan, not PET scan though, but on scan, and was told that she had disseminated malignancy, went on a big trip and came back and there was nothing left.